Erin, and this is Amanda. We're physical therapists here at Milford Regional Medical Center, and we specialize in women's health, physical therapy. We both work at our Northbridge Clinic, and today we're here to talk to you about our women's health physical therapy program. Today during our presentation, we're going to talk to you about what women's health physical therapy is, the pelvic floor anatomy, what a bladder function does under normal conditions, the different types of urinary incontinence, changes in the pelvic region during pregnancy and following delivery, what a prolapse is and the different kinds, and pelvic pain. Women's health physical therapy is physical therapy that focuses on the functions from the pelvis and groin area that contribute to bladder or bowel dysfunction, sexual health dysfunction, and pain. It's a non-surgical team approach that has a physical therapist who has had additional training in the women's health field study. Here is a list of common diagnoses that we see at our clinic. It's not limited to this list, but this is our most common diagnosis that we see. This is often an underserved population. A lot of these patients don't talk about these symptoms and go untreated for a number of years, but it is quite common to have any of these issues. 1 in 4 U.S. women will report a pelvic floor dysfunction at some point in their life. I've mentioned multiple times during this presentation already the pelvic floor, but what is it? Your pelvic floor is a group of muscles in men and women that create a hammock or a sling at the base of the pelvis. They support our internal organs and control defecation and nutrition. When these muscles tighten and contract, they close around the openings around your urethra, vaginal canal, and rectum, and lift our internal organs. When these muscles relax, they allow for passage of a bowel movement, urination, and delivery of a baby, and also to partake in intercourse. Now, just to give you a visual with our model, your pelvic floor is a bowl at the base of your pelvis, and also on the outside as well. It goes from your pubic bone all the way to your tailbone. Now, let's talk about how the bladder functions under normal conditions. It is important to remember during this lecture that continence is the voluntary control of both bladder and bowel functions. Under normal conditions, our bladder holds between 400 and 600 milliliters of urine. As our bladder begins to fill, it starts to stretch, and that usually occurs about 150 to 200 milliliters. As the walls of our bladder begin to stretch, about 150 to 200 milliliters, it sends a signal to our brain that tells us that we need to urinate soon. Normally, this signal is delayed by the help of our pelvic floor muscles until our bladder is full and we have a chance to visit the restroom. Until that time, our pelvic floor muscles will stay contracted and the detrusor muscle that's within our bladder walls will stay relaxed. Once our bladder is full and it's time for us to use the restroom and void, the pelvic floor muscles will relax and our detrusor muscle will contract, allowing us to urinate. Normally, it takes about at least 8 seconds to fully empty your bladder, so the next time you use the bathroom, count how many seconds it takes you to void. If it takes you less than 8 seconds, you went too soon and your bladder wasn't full. Normally, it takes about 3 to 4 hours for your bladder to fill, and that gives you an average of 5 to 8 times to void per day and 0 to 1 times per night. Now, what things help my bladder work better to keep it healthy? So drinking enough water is important. A lot of our patients will tell us they go without drinking in order to stop urinating as frequently as they do. What this does is it actually concentrates the urine within your bladder and it irritates your bladder walls and the lining. There's also some foods and some fluids that irritate the lining of our bladder and make our bladder more excited, and it increases the urgency in our bladder, and they're listed on this screen. Alcohol, tomato-based products, caffeine, coffee, tea, any sodas, carbonated drinks, food coloring, artificial sweeteners, citrus fruits, spicy foods, candy, chocolate, and dairy products. Eating enough fiber is also important for our bladder, as when you are constipated and you strain to have a bowel movement, it puts a lot of strain on our pelvic floor, making them less efficient. Now, what am I doing that's making my bladder work harder? So a lot of people will go just in case. We see this a lot with our patients in the clinic. I'll have women tell me that they go to the bathroom before they left their home, when they get to the clinic, and before they leave. That's 3 times within an hour and a half. As we learned in the previous slides, it takes 3 to 4 hours for your bladder to fill. So try to avoid going just in case. Also, a big spike that we saw during the COVID-19 pandemic was hovering or squatting over the toilet. What this does is it sends mixed signals to your pelvic floor. You're telling your muscles to stay contracted and tight so you don't fall into the toilet, but also to relax in order for you to urinate. Some others is avoiding drinking fluids, as we talked about before, and habitual holding. And what this is avoiding going to the bathroom, either because you have fear of using a public toilet or you don't have time during your day. We see this a lot with healthcare workers and with teachers, that they just don't have an opportunity to use the restroom during their work shift. Lastly is tightening your pelvic floor while you're urinating. People will say that they're trying to do a Kegel while they're urinating, and again, this sends mixed signals to your pelvic floor as it begins to tighten while you're trying to have it relax in order to urinate. Now, just to give you all a visual of how much your bladder stretches when it's full, you should be able to hold 400 to 600 milliliters of fluid, and that's a whole water bottle. When you get the first urge to urinate, your bladder is about half full, and that's about half a water bottle. And again, you still have time to wait because it should be able to stretch to a whole water bottle worth of urine.
We're going to review now incontinence, which is a very common problem many women have over the course of their life at different ages. It's any loss of fecal or urine matter. Incontinence has many risk factors. These are the risk factors: age, history of pregnancy, childbirth, menopause, hysterectomy, obesity, and impact sports. Then there's different types of incontinences: urge, stress, mixed, and overactive. And we'll go into describing them. The first type of incontinence we'll talk about is urge. Any involuntary loss of urine preceded by a strong desire to void. That's usually urge. You have a strong urge to go. And it usually associated with certain types of triggers. And some of those can be running water, cold, entering the house or room. You can put a key in the door, getting out of your car, pulling into the garage, and walking by the bathroom, walking by, again, like a faucet being turned on. The common symptoms with urge incontinence, a lot of times women feel such a strong urge they lose urine on the way to the bathroom. And then another example is they have such a strong urge they feel loss of urine when they go to pull their pants down. They can't quite sit on the toilet before they feel loss of urine. Next one, we're going to talk about stress incontinence. Stress is any loss of urine with a physical activity, and that includes, it can be as simple as coughing, laughing, even blowing your nose sometimes. Jumping is the physical exertion, or running, and sometimes even walking. Women will say they lose urine, as well as standing up. Mixed incontinence is just a combination of both stress and urge. So some women can have just stress, some women can have just urge, and other women can have we see women with a combination of both kinds. Overactive bladder involves symptoms of urgency, frequency, incomplete voiding with or without pain and leakage. A lot of times these women, they're going right before bed, they wake up, then they feel like they've got to go again. They go multiple times during the night. They're always looking for a bathroom. They always are constantly going, and they don't ever feel like they're getting it all out, even when they do go to the bathroom. And then they never want to drive too far. Traveling is an issue. They're always worried about where the next bathroom is, because they're going half hour or sometimes even less. And then the last one, getting off the toilet and feeling like you need to urinate, and then they start to leak again. Okay, we're going to move on to pregnancy and talk about pregnancy and postpartum a little bit at the same time. When we look at pregnancy and our changes in anatomy, we focus on our belly muscles and our pelvic floor muscles. And when we look at our belly muscles, our transverse abdominal, those are our deep abdominal muscles that wrap around us. They tend to, as our bigger abdominal muscles in the front, they tend to stretch up. They're all stretching out as we progress through pregnancy. So then we look at, in terms of postpartum, they then weaken, they're deflated, I like to call them. They're now weakened because they've been stretched during the whole time of pregnancy. In terms of your pelvic floor muscles, as you're pregnant, again, those are being stretched and potentially weakened if you're not conditioning them the right way. Postpartum, they'll stay weakened if we're not actively doing exercises to keep them strong. And we'll talk a little bit further down the road about how this perpetuates and can lead to incontinence issues as well. In terms of exercising, when we look at pregnancy and postpartum, it is safe to do exercises while you're pregnant, especially for your deep transverse abdominal muscles and your pelvic floor. Many women think that they can't, and there's simple basic ones that you can do and keep, even if you haven't done them before pregnancy, you can start them during pregnancy and continue them. In terms of postpartum, your OBGYN will give you the okay around that 6-month follow-up to begin exercising again. Nearly 70% of postpartum women describe at least one physical problem within a year of giving birth. Those can be postpartum depression, fatigue, lack of sleep, pain, breastfeeding difficulties, lack of sexual desire, and urinary or fecal incontinence. And then the risks for postpartum incontinence, which we started to get into a little bit, include vaginal or vacuum delivery forceps, injury during delivery, excess weight, previous incontinence issues, pregnant with multiples, and previous pregnancies. So I put the bottom slide on to point out a lot of times we get stuck postpartum around the third one in. When we start to recover, we don't fully address our pelvic floor and our abdominal muscles. And that's then where you start to see the incontinence cropping up. Prolapse is the descenter, one or more of the anterior vaginal wall, posterior vaginal wall of the uterus, or the apex of the vagina. And that the apex of the vagina usually happens post-hysterectomy. The symptoms you feel with a prolapse is any kind of bulging, pelvic pressure, low back pain, bleeding, discharge, infection, and then splinting is another common symptom. Women will feel like they have to insert a finger or push rectally or on the perineal body to relieve themselves that way. It's a common issue, and women again, we don't address it enough. The risk factors for prolapse: childbirth is a big one. Straining, obviously, during the first stages of labor increases that risk. Use of forceps, prolongation of the second stage of labor, rapid succession of pregnancies, and the badly repaired perineal tears. Any pregnancy is going to increase your risk for a prolapse. Postmenopausal atrophy is another one. So when the estrogen deficiency when you get estrogen deficient, the postmenopausal atrophy is another risk factor. Estrogen deficiency causes weakness in the connective tissue. Raised intra-abdominal pressures, that happens with heavy lifting, so it can happen to athletes too. And straining when you're on the toilet is another big risk factor that women don't realize. If you're always straining, constipated to go, then you're increasing your risk of having that prolapse happen. And COPD with all the coughing is another risk factor. And hysterectomy, as we already talked about, is a risk factor for any of that descent of your vaginal walls causing that prolapse.
Now I want to talk to you all about pelvic pain. Just like incontinence or prolapse, Pelvic pain is a symptom patients often feel times that they can't go to their provider about because they're embarrassed or uncomfortable discussing this. But it's really very common. Research suggests that 1 in 7 women ages between 18 and 50 have some sort of pelvic pain. It makes up 61% have no diagnosis, but that leads to 10% of our gynecological visits, 20% of laparoscopic surgeries, and 12 to 16% of hysterectomies. And as Amanda said, having a hysterectomy puts you at more of a risk for prolapse and issues down the road. It has a really big impact on their quality of life. 25% spend 2 to 3 days a month in bed, and over 50% limit their daily activities 1 to 3 days out of the month. 90% have pain with intercourse, either with initial penetration or with deep penetration. And 50% feel sad or depressed because of their pelvic pain symptoms. Often these patients are people that suffer alone because you can't go to work and say, my pelvis hurts today. So a lot of this goes underreported. How do I know if I have pelvic pain? Often these patients will have pain that lasts over 3 months. The pain is usually located in their lower abdomen, vulva or vaginal region, their perineum, anus or tailbone. You can also have low back or hip pain. We see quite a few orthopedic patients that end up getting referred to women's health physical therapy because their orthopedic physical therapist is unable to help them with their pain since it is internal and in their pelvic floors. A lot of times these patients will have difficulty voiding or defecating, like I said, pain with intercourse, pain with sitting or prolonged standing, difficulty wearing tight clothing, and difficulty sleeping. Sometimes these patients have a history of sexual trauma, but oftentimes patients have no underlying injury or reason to why these pain symptoms manifested. Now, if I need women's health physical therapy, what should I expect on my first evaluation? Your evaluation will be done with a specialist in women's health, so you can rest assured that it will not just be a regular physical therapist. They will have specific training after they've graduated college in women's health, and it will be in a private room. It won't be in the middle of the gym. They'll take a full review of your medical history, your eating, drinking, and bathroom habits. And just like with orthopedic physical therapy, if you were to come for your knee or your hip or another joint, they're going to do a full external body exam with a postural assessment, spine and hip range of motion assessment, and strength assessment involving your core and hip musculature. Oftentimes, your physical therapist may feel that more information is needed, and they'll recommend an internal pelvic exam. This is done to assess the tightness and strength of your pelvic floor muscles, and is done with a single gloved finger. There's no speculum or stirrups in our clinic. From the evaluation, you and your physical therapist will set goals and come up with a treatment plan that's tailored to you and your symptoms and your functional limitations. Now here's a list on the slide of all the tools and strategies that we have in our clinic. I want you to take note that not all of these treatments are appropriate or warranted for each patient. Again, we do tailor our treatment specifically to the patient's needs and our findings on our evaluation. But here are some possible treatment plans that we have in our clinic. Now, if you have some of these issues and you're wondering how to get help, reach out to your doctor and ask them for a referral to physical therapy for women's health. We have 2 locations where we have specialists in women's health, our Milford Clinic and our Northbridge Clinic, and we'll be happy to see you there. Thank you again for watching our presentation. If you feel that you have any of these symptoms that we talked about on any of our slides, please feel free to reach out to your physician and ask them for a referral. We'll be happy to help you.